Hello and welcome to the New School OBGYN podcast, a podcast in women's health, but for everyone. Our goal is to promote good and reliable knowledge because the source of your information matters. I'm Eric Schmidt, board certified OBGYN. Today I have back with me Taryn Miyaoka. She is here to talk about gestational diabetes because we did our first talk on gestational diabetes. If you haven't listened to that, just go back a few episodes and listen to it. We talked about the diagnosis previously. Now we want to talk about once someone's has the diagnosis and what to go from there. So gestational diabetes part 2, we'll call it. Again, Taryn is a physician associate in women's health. And go ahead, Taryn, what are we going over today?
So in this episode, we have gestational diabetes. You've been diagnosed. So kind of now what's next? What steps? What does that look like?
Okay. And, first off, I like to kind of start off by saying, like, not all gestational diabetes is created equal and the same. There are, I think, some subset of people who have real risk factors for gestational diabetes and they are at higher risk for treatment. But I think there's also a subset of people where they just don't do well with those glucose tests we give them, and it's such a higher dosage of glucose than they normally get that their body just doesn't make enough insulin. But so not is all created equal, but we have a couple of ways to classify gestational diabetes, Taryn. And what do we call that, just for as we use these terms so people know?
Yeah. So people will say like GDMA1, which means that you don't need any medication. You're kind of just managing it with like lifestyle changes, dietary changes, those kind of things. And then GDMA2 is when you do need a medication to kind of help with those blood sugars.
So you might hear us abbreviate that way, or just say A1 or A2.
Yeah.
But, again, one might ask, why do we treat? And if you listen to the last podcast, there's the definite maternal and fetal risks that can come with uncontrolled gestational diabetes. And so refer to that back to that podcast. But okay, I just unfortunately I didn't pass my 1 hour, Taryn. It was really gross. That's actually not that bad. We tried it on that previous episode.
Yeah.
And then I took my 3 hour test, or if I just took a 2 hour test and I didn't pass that one too, I now have met the diagnosis of gestational diabetes. What do I do now?
Well, we want to get a look at kind of what those numbers are looking like throughout the day. And so you will get some supplies from your provider to start checking your blood sugars. And that's typically just like that finger poke. I've done this before. It's not that bad, although I will say I'm sure it gets annoying to do it multiple times a day. But
it's kind of scary. Like,
yeah.
I'm apprehending. I wouldn't say scary is the right word, but like the few times I've done it, like to prick the finger with a little lancet is.
Yeah. I mean, who likes the idea of pricking themselves with a needle?
But it doesn't really actually hurt.
Yeah. So you want to check it, or typically we'll tell people to check it in the morning when you're fasting. So this is just, you haven't had anything to eat, just kind of seeing what that level is. And then usually typically in our practice, I would say we do it at 2 hours after you've had a meal. So you're checking it about 4 times a day. Then we, tracking those numbers and actually writing it down and keeping a log is really helpful to bring in to your provider, because then it gives us a good picture of kind of what's happening day to day, and also just not a one-time snapshot. Like if you had a hamburger, odds are that's going to be a much higher number versus if your normal dietary intake is pretty,
right,
much less than that, then those numbers tend to be okay. And so it helps us kind of see what that range looks like and how often there are those outliers versus is it consistently high. Right. So yeah, people typically do the finger pricks. Sometimes people will do continuous glucose monitoring. That is something that is becoming more and more covered by insurance. So that's always something you could talk to your provider about. And then again, we talked about that. A1 is that dietary lifestyle changes that you could implement. About 85% of women can manage their gestational diabetes with these diet and lifestyle changes. So what would those look like?
Well, I want to go back just a little bit.
Okay.
What is a continuous glucose monitor?
So typically it's like a wearable, right? Usually on typically the arm.
Yeah.
And basically it's just, I don't even know. Like I don't know how to describe it without saying the words.
It gets the tissue so it has a continuous monitoring of the tissue levels of the glucose. And so, if you see somebody walking around with one of those, either like a little patch that goes to the arm or a little thing around the waist or something like that, there's kind of two different things it could potentially be. It's a potential monitor or an actual device that's administering insulins. And so, for the treatment. And so, but this one's just the monitoring for, to see what the glucose levels are. And it gives you kind of what on the app of the phone, the patient can pull it up and, it continuously checks it throughout the day. And so what's kind of nice is you're not feeling those pokes and you don't have to worry about the pokes, and continue to go through that process or forgetting to do it after a lunch or dinner or something like that. So, yeah. But getting back on track, so most people can control it with just dietary changes. And I think it's a good time for us all to evaluate what we eat and drink and how that impacts our body. But some of the dietary changes I think that we can make, and some of the easiest changes that we can make when we're diagnosed with gestational diabetes, is to eliminate soft drinks, eliminate sugary drinks, or those drinkable, easy way to get sugar in, because those are going to get into your bloodstream a lot quicker and cause those spikes in the blood sugar, which can be a little more dangerous to the pregnancy and the baby. And so I think that's the easiest fix, is just eliminate those drinks or the big Starbucks, like I don't even know, caramel macchiato.
Yeah.
Even though caramel macchiato in real life is like different. Anyway, and what else you want to evaluate too is the other sources of carbohydrates, and really simple ones. Those would be like your white rices, your white breads, tortillas. Every kind of culture has their own source of like their, whether it's any of these, and try to reduce those because they, and just evaluate. And being consistent with all this is pretty important too. In, sorry, dogs are in here. Being consistent is also important. And as far as like calorie amounts and calorie numbers, we don't necessarily encourage patients to like restrict their calories just because of the gestational diabetes. Diabetes is more about like choosing smarter calories. And so this would be more complex carbohydrates, the brown rices, the wheat breads, those type of things. And I always think it's important, and we usually are pretty good with this in our clinic, is referring people out to a nutritionist to help them with making these changes, because there's sometimes only so much time in a single visit, which we can go over a lot of these details, and they can go over a lot in pretty good detail. So, yeah.
One thing I guess two things I would add that I typically tell patients is focus on like protein intake. I think it's easy, especially when you're on the go or you're like nauseous and things like that, to just kind of go for something that tends to be like higher carb, even like a banana. That's something that definitely could spike your blood sugar, even though it's a fruit. And so always pairing any kind of source of maybe more sugar or carbs with a good amount of protein. And this can also come in those kind of complex carbs, but like fiber intake is also really important, which will also help with constipation, which tends to be an issue too.
Big issue.
So I always recommend trying to think about that.
No, that's very good. And trying to get those things so the simple sugars don't get absorbed so quick and get lower down into the GI system. And so I think sometimes patients, they might start checking their numbers right away. And we have these parameters, which Seth will tell you here in a second, about what to expect with each of those numbers. And they're like, oh my gosh, that one's high. Yeah. And it's like, yep, but we need to evaluate this over time a little bit. What happens if my numbers are high? How do we generally do this, Taryn, if you want to?
So again, we're checking like those fasting and those post-meal numbers. And typically we want them to be less than 95 for fasting. Or I guess, we categorize as high if they're over 95 for fasting and over 120 2 hours.
I tried to trip you up there.
I know. I was like, this is the opposite. And again, like Dr. Schmidt said, isolated numbers or just like isolated elevations aren't as concerning, especially, sometimes people will write down what they ate next to their numbers. And I think that can be helpful too when you kind of see like what are your triggers, something that you might not think be a big impact on your blood sugar could be. And so if you start to notice those trends, again, I don't like telling people to have to like cut out things completely, but reducing those or making sure, again, you're eating that with like a high protein meal can be helpful. So as annoying as it can be, kind of taking account of, your diet and writing that down can be a good way to evaluate it.
Yeah, that's a good point that I forgot to mention earlier is the importance of tracking your, what you're eating so you can see those trends.
Yeah. But yeah, usually we'll say, if you're having 25 to 30% of elevated numbers in about a week, then, a lot of times we'll start medication. And again, that's why it's so important to bring in that log, because the more numbers we have, the best, like the better informed decision we can make to kind of more individualize your care.
Right. Yeah. And sometimes, it's okay to forget a number, or if you don't eat a meal, you don't have to take that value. But for the most part, as long as you can get us some of that more information, we can make the best judgment on, do we need to start treatment, which again could be like oral medications like metformin, which, it's not perfect. It may help a little bit with the insulin resistance of pregnancy. But otherwise the, treatment would be like injectable insulins. And so, but again, hopefully we can control this all with just diet and exercise. And I didn't mention exercise, but that would also be, and I think during your pregnancy, you guys did a really good job of keeping active and, because exercise, as we know, plays a part in it too.
Yeah. And I have had, one of my colleagues told me that if you have maybe a higher carb meal or something like that, or just in general, a good practice is if you take about like even a 10-minute walk within the first 2 hours of finishing a meal, that can definitely help blunt that kind of blood sugar spike. So that can be really helpful and isn't too time consuming. So if you can kind of manage to do that, that can, some people will see changes there.
Right. That's perfect. And yeah, so with a diagnosis of diabetes, and, it does have potential, concerns regarding making the pregnancy a little bit higher risk. How do we make sure baby's doing well through all this?
So big thing we think about, we again talked about risk factors previously, is growth. How's baby growing? Are they growing appropriately, whether too small or too big? And so a lot of times we always do those fundal heights, but usually, especially if you have a diagnosis of diabetes, there'll always be like a growth ultrasound. Usually I see people do around 35, 36 weeks typically.
Yeah, because they're getting kind of closer to delivery. Getting the growth ultrasound, check on baby's growth and fluid levels, and making sure the diabetes isn't having too much of an impact on baby. And then, other tests we can do. And again, going back to those terms, if someone is a GDMA1, meaning they're not on medications, they're well controlled, they're doing great with their diet, they might not need, we'll probably get like a growth ultrasound for them, but we're not going to do what I'm going to say next usually, which is like an NST or a BPP, which is how we assess our babies doing well inside mom's belly. 2 different tests that we can do in the office, listen to baby's heartbeat or go on ultrasound and look at a few parameters to make sure baby's meeting those criteria. But if someone has, so we would do that in someone that had higher numbers on insulins and those type of situations to try and figure out when is the best time for their delivery. Because again, if someone's well controlled just by diet, that means that baby's really not seeing a lot of high numbers, and that person maybe doesn't really need any interventions and hopefully have a normal, spontaneous labor and delivery process that isn't impacted by the diagnosis of the diabetes. But if someone is having more difficulty controlling their numbers, we see baby being affected by the amount of glucose with, increased growth, increased fluid. We might do those NST or BPPs and potentially plan for delivery a little bit before the due date. And that can vary. That could be a week early, could be potentially 2 weeks early, could be even earlier if there's any issues with really high numbers or really bad noncompliance. But we try not to deliver much sooner than we have to. Kind of a question I get a lot: can we have vaginal delivery with diabetes?
I mean, yes,
Yeah.
absolutely. You can.
Yeah. Just to, it shouldn't hopefully scare too much. It's something we deal with a lot and every day, and we might talk about certain risk factors, but if it's decently well controlled, it really doesn't make a pregnancy that much more risky.
Do you ever counsel based on what they see on the growth ultrasound? Let's say you're 99 percentile on growth.
We do.
Do you say, do you deliver earlier because of that? Do you counsel maybe a C-section would be better? How do you navigate that?
It can be tricky, and you might get a few different answers depending on who you talk to.
Yeah.
And to what degree, because I think some of the growth measurement algorithms that the computer uses to measure growth are a little dated, and as a culture, we're just becoming bigger. And so it's more and more commonly that you see a baby that in our eyes is normally grown, but on the growth scale, they're kind of at the top. But if a baby is growing big, let's say 90th percentile or bigger, especially if they have diabetes, there's definitely conversations that are had where, if we're planning for a delivery, there is a chance that there could be some potential complications with delivery, albeit rare, serious complications if baby's too big, specifically that midsection. There could be some difficulty getting those shoulders and that belly out. We call that shoulder dystocia. It's one of the scarier things we do see as OB providers. And so we counsel on it. It's still a rare thing. But if baby's growing so big, and we do have certain numbers for this, I won't necessarily get into that too much, but if someone has a diagnosis of diabetes and let's say estimated weight is greater than 4,500 grams, we might recommend a C-section because that risk becomes so high of baby getting stuck and potential serious complications for baby and mom that we might work more towards a C-section is potentially safer for baby.
I would say that's that's a pretty big baby. I would say we don't see that often in our practice, right? I haven't personally.
Yeah, it is. Well, and here's the thing too, is ultrasound's only so good, especially later on. People do ask my baby's, do you change my due date with an ultrasound in the third trimester? It's like, no, that's actually the more accurate ultrasounds earlier on. And so these are just showing that your baby's growing bigger. But if you're getting an ultrasound at 36 weeks, 38 weeks, baby could be measuring off by like a pound or two. And so it's quite often where we measure babies big and they turn out to be a little bit smaller. But it also could be the reverse. Baby could be a pound or two bigger. And so it's only so good. It can be a little bit of mystery, but that's why we're always ready for for those type of situations. And we drill for that kind of stuff on labor and delivery and have special classes for that. So to manage those emergencies, but went down a little bit of rabbit hole, but that was good.
Yeah. I mean, that's all to say.
Yeah.
Things are individualized.
Yeah.
It's not a clear, yes, you can, yes, you can't. So talk to your provider and hopefully you can make the best decision for you.
Yeah. Anything else you want to add on this one about gestational diabetes?
No, I'll just make my one little quip, which I think I also said in the last gestational diabetes podcast, is that if you have gestational diabetes, try not to see it as a failure or you did something wrong.
Right.
There are modifiable risk factors. There are things still outside of your control.
Yeah.
And just do your best. It's okay.
Right. I mean, and like you said, we talked about it before, but only so much is under the mom's control with the pregnancy hormones and everything that's going on. But sometimes it's actually good, to kind of have this situation that comes in life that makes you evaluate things. With certain situations, this one's will be evaluating the diet and exercise, and it might be sometimes for people, I think, is a good way to get them to, for the pregnancy and beyond, to learn more about what impacts blood sugar and what consequences that could have. So not always a negative.
Yeah, not too late to make changes.
And we're finding the positive out there. So perfect. Well, we just talked about gestational diabetes. Again, this was part 2 in, I think, a part 2 series. So I don't know if we're going to, beyond this, we're not going to talk as much about the management in labor and stuff like that. It can be a little tricky, but not necessarily for the purpose of this podcast. So thanks everybody for listening. And as always, YouTube video hopefully going up soon. The content of this podcast and video are for educational purposes only. None of the content is meant for personal medical advice. Please contact your provider if you're in need of personal medical advice. Thank you, everybody. Have a good day.